Welcome to Roadmap to Residency. Hello everyone, I'm Abhiraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. So in this video, we will be also discussing about pancreas and pancreatitis. So based on the clinical presentation and findings, which of the following complications of pancreatitis is most likely in this patient, and what additional test is necessary to confirm the diagnosis? A 45-year-old man with a history of alcohol abuse presents to the emergency department with severe epigastric pain that radiates to his back. He reports that the pain started shortly after consuming a large meal and has persisted for several hours. He also complains of nausea and vomiting. Physical examination reveals tenderness in the region, in the epigastric region, and significant guarding upon palpation. Lab tests show elevated serum lipase levels. Abdominal ultrasound is unremarkable based on the clinical presentation and findings. Which of the following complications of pancreatitis is most likely in this patient? So the question has already told us about the diagnosis. And what additional test is necessary to confirm the diagnosis? Acute cholangitis, MRCP, pancreatic pseudocyst, CT scan, acute peritonitis, DPL, pancreatic abscess, FNA, splenic vein thrombosis, duplex ultrasonography. We will come back to this question, but first let's discuss about what is required to answer this question. That is the theory part. The anatomy of pancreas, there are the three different parts of the pancreas: the head, body, and tail. There is the main pancreatic duct of Wilson that just evacuates into the duodenum through the ampulla of Vater. And there's accessory duct of Santorini. And this is just a magnified image. There you can see that these are the acini which produce the digestive enzymes, and these are the acinar ducts. This is the intercalactic duct, and this is the interlobular duct which secretes the sodium bicarbonate, and this is the main duct. And through the main duct, now the enzymes just gets transported towards the duodenum. Also, here you can see, due to the food, when we ingest the food, there is a secretion of the gastric acid and lipids, and the gastric acids also leads to the increase in the secretin level. So the lipids leads to the increase in the cholecystokinin level, which leads to the movement of the acini and all. Okay, and then the enzymes are just gets transferred towards the main duct. Also, due to the cephalic action of acetylcholine and all, or due to the action of the gastric and the intestinal modulators, there is increase in the secretion. Also, the islets of the Langerhans gets stimulated by the insulin glucagon and the somatostatin, and then the enzyme gets secreted. So this picture shows us that the neurohormonal control of the pancreatic function, the stimulatory and inhibitory functions stem from the vagus and sympathetic nerves and the gastrointestinal hormones. The cholecystokinin and secretin play the pivotal role in stimulating the pancreatic secretion, acetylcholine. Now let's talk about the acute pancreatitis. So acute inflammation of the exocrine pancreas caused by the activation of intrapancreatic enzymes causing autodigestion of the pancreatic tissue. The epidemiology, pathogenesis, and histology: alcohol abuse and gallstones are the major causes. Must be activation of pancreatic proenzymes. The activation leads to the autodigestion of the pancreas. The mechanism of the activation of proenzymes include obstruction of the main pancreatic duct or terminal common bile duct. Now, it is caused by the gallstones, which is most often occurs in the woman. It is due to the thickened ductal secretions related to the alcohol, which also increases the duct permeability. Also, there may be a pancreatic tumor, some toxins like a scorpion venom, and drugs. Okay, so that one mnemonic you might have remember about pancreatitis, that is, I get smashed. Now, there are other causes like the hypertriglyceridemia, hypercalcemia, infection like CMV, mumps, Coxsackie virus, mechanical like examples like seatbelt trauma, bicycle handlebar, vascular like vasculitis, ischemia after cardiac surgery, hereditary like mutations in the cationic trypsinogen gene, pancreatic secretory trypsin inhibitor SPINK1, and the miscellaneous like idiopathic hypothermia and autoimmune pancreatitis. The trypsin is important in the activation of proenzymes. The proteases damage the acinar cell structure. lipases, and phospholipases, producing the enzymatic fat necrosis. The elastases damage the vessel walls and induce the hemorrhage. The activated enzymes also circulate in the blood, causing damage in the distant sites. The clinical findings include the fever, nausea, and vomiting. The severe or boring knife-like mid-epigastric pain with radiation into the back. Radiation to the back is caused by the retroperitoneal location of the pancreas. And also there is hypovolemic shock, which is caused by the third space fluid loss. There may be hypoxemia. So the circulating pancreatic phospholipase destroys the surfactant, and the loss of surfactant induces the atelectasis and intrapulmonary shunting. So there can be acute respiratory distress syndrome in case of pancreatitis. The gray Dorner sign, that is the flying hemorrhage, the Cullen sign, that is the periumbilical hemorrhage, may be seen in cases of pancreatitis. The BIC tetani can be seen. And let's talk about now the important thing, that is the lab findings in the acute pancreatitis. So the level of enzymes does not correlate with the severity of the disease. So there may be increase in the serum amylase, which is usually 3 times normal level. It is not specific for pancreatitis, and sensitivity, it has sensitivity of 85% for the diagnosing of the acute pancreatitis. Initial increase in the amylase occurs after the 2 to 12 hours, and it peaks over 12 to 13 hours and returns to the normal in 2 to 4 days because of the increased renal clearance of the enzyme. The amylase is present in the urine for 1 to 14 days, and persistent increase in the serum amylase for more than 7 days suggests the presence of pancreatic pseudocyst. Increase in the urine amylase, initial increase occurs over the 4 to 8 hours, and it peaks at 18 to 36 hours and returns to normal level over 7 to 10 days. The increase in the serum lipase, more specific for the acute pancreatitis than amylase, and it is not excreted in the urine. The initial increase in the serum lipase occurs in 3 to 6 hours, and it peaks into 12 to 30 hours and returns to normal in 7 to 14 days. The serum ALT, so the elevation of ALT is 3 times normal, suggests a gallstone obstructing the common bile duct as the cause of pancreatitis. The increase in the serum immunoreactive trypsin can also be seen. Decrease in the fecal elastase is very sensitive and specific just for pancreatic exocrine dysfunction. There can be absolute neutrophilic leukocytosis, hypercalcemia, and hyperglycemia. This is just a flow chart where you can see the serum amylase and lipase in the course of acute pancreatitis. So lipase persists for a longer time. Amylase and lipase rise in serum at the same rate. The amylase remains detectable in the urine longer than the serum. This is the CT image showing the acute pancreatitis here. Now, pathogenesis of acute pancreatitis. So due to the bile stones, or due to the alcohol, or due to the overeating, like in our patient, he ate a lot of food, overeating, or in the increased demand. These all lead to the tissue injury. Also, the tissue injury can be due to the viruses, drugs, and trauma surgery. And then due to the activated enzymes, there is a necrosis and leakage of the enzymes, enzymatic fat necrosis, vessel wall necrosis leading to the hemorrhage, and enzymes in the bloodstream. So these enzymes are then detected into the lab values. Also, you can see that the gallstone impacts and leads to the reflux of bile. The alcohol leads to the spasm of the sphincter of Oddi, intraductal protein precipitation, and it also has effects on the acini. You can see that the gross appearance of the acute pancreatitis. Note the massive hemorrhage into the pancreas, which appears edematous, and you can see in the histological image the necrotic foci and fat necrosis, which are scattered throughout the parenchyma. Now, the chronic pancreatitis may lead to the formation of ductal stones, pseudocyst, calcification of fibrosis that entraps the nerves, causing the pain. Now, talking about the chronic pancreatitis, the symptoms are related to the destruction of the acini and consequent pancreatic insufficiency. Destruction of the islet of Langerhans may cause secondary diabetes mellitus, and pain results from the knot trapping in the fibrous tissue. Calcification and interductal stones may be seen radiographically. You can see the chronic complication leading to the pancreatic cirrhosis, which is very, very often tested in the USMLE step 1 examination. The PP here demonstrates the pancreatic cirrhosis, which is a potential complication of chronic pancreatitis. The CT image showing the diffuse dystrophic calcification of the pancreas in the patient with chronic pancreatitis. It is due to the saponification process. Again, very highly tested in the USMLE step 1 examination. Now let's coming back to the question. The most likely complication of pancreatitis in this patient is pancreatic abscess, and the necessary additional test to confirm the diagnosis is fine needle aspiration biopsy. The key findings include the severe epigastric pain, nausea and vomiting, tenderness and guarding, elevated serum lipase, and abdominal ultrasound. So the severe epigastric pain, the patient presents with severe epigastric pain that radiates to his back, which is characteristic of acute pancreatitis. This condition is often triggered by factors such as heavy alcohol consumption or a large meal. Nausea and vomiting are the common symptoms in acute pancreatitis, reflecting the GI involvement. Tenderness and guarding in the physical examination. So findings of the tenderness in the epigastric region and significant guarding. Often palpation suggests the peritoneal involvement, which can be seen in the severe cases of pancreatitis and with complication. Elevated serum lipase are a hallmark of pancreatitis, confirming the diagnosis. Abdominal ultrasound that is unremarkable suggests that there are no gallstones or obstructive biliary pathology contributing to the pancreatitis. However, it does not rule out complications of pancreatitis. In this patient, the combination of severe epigastric pain, nausea, vomiting, significant guarding, and elevated serum lipase levels suggest a severe form of acute pancreatitis with possible complication. Pancreatic abscess is a known complication of pancreatitis characterized by localized collection of pus within or around the pancreas. The diagnosis of the pancreatic abscess often requires FNA biopsy to confirm the presence of pus and to guide further management. Psychic cholangitis typically presents with fever, jaundice, and right upper quadrant pain, and MRCP may be used to assess the biliary tree, but is not the primary concern in this patient. Pancreatic cirrhosis is a fluid collection that typically develops at least 4 weeks after the onset of pancreatitis. This patient's presentation and findings are more suggestive of a more acute complication. Acute peritonitis is characterized by the diffuse abdominal pain, rigidity, and guarding, often resulting from the perforation of a hollow viscus. Diagnostic peritoneal lavage is typically not used to diagnose pancreatitis or its complications. Splenic vein thrombosis is a less common complication of pancreatitis. Now, the duplex ultrasonography may be used to evaluate the splenic vein, but this is not the primary concern based on the patient's clinical presentation. That concludes our discussion on the pancreas and pancreatitis. Thank you for watching.